Good afternoon, and welcome to HealthSystemCIO.com All-Stars panel, getting up to speed on EHR Contingency Plan requirements, a webinar tweet chat combo from HealthSystemCIO.com. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your webinar moderator today. We do have a simultaneous tweet chat going on, hosted by Managing Editor and Director of Social Media, Kate Gamble. You can participate, if you want, using a separate browser or on your phone, and use the hashtag HSCIOchat. If you want to just view the tweet chat while we're doing the webinar here, you can open the Media Viewer panel on the right-hand side of your screen. Other WebEx panels we'll be using today are the polling panel and the Q&A panel, and if you want to submit a question, you can do so at any time in the Q&A panel. We'll leave the default set to all panelists, and we'll take those later in the program. You can download the deck using the URL on your screen, and it will also be sent out in the chat box during the event. Okay, just so you see how we're going to spend our time, we're going to go 40 to 45 minutes. First, we're going to have our panel discussion with Dan Morreale, SVP and CIO at Hunterdon Healthcare, and Ed Ricks, VP and CIO at Beaufort Memorial Hospital, and then we will take your questions. So, without any further delay, we're going to jump right in. Ed, let's start with you. Can I get a little bit about your organization, please?
Yeah, sure. Thanks, Anthony. I like to call us like the perfect example of a community hospital. So we're a 197-bed private, not-for-profit community hospital in Beaufort, South Carolina. If you're not familiar with South Carolina, a lot of times I'll have some slide deck and a picture, but our hospital is literally on the coast, on the water. We're about 60 feet from the edge of the water at the back edge of the building. So as you could probably guess, disaster recovery and contingency plans is something that we do talk about down here. But we're kind of a full-service community hospital, very busy, $125 million a year. All service lines. We, like many organizations now, employ a fair number of physicians in the town, although there are still some independent practices, and getting busier all the time and expanding outpatient services.
Very good. Dan?
Yes, good afternoon, and thank you for this opportunity, Anthony. Hunterdon Healthcare System is located in central western New Jersey. It too is a community hospital having just under 200 beds. Hunterdon's claim to fame is that it was founded in the mid-50s under the auspices of improving the health of the population. So for the past 60 years, Hunterdon has been concentrating on population health. We have 60 ambulatory sites and do approximately 1 million ambulatory visits each year.
Very good, very good. Thank you. All right, let's jump right in with Dan. Let's start with you on this one. Talk about your current EHR contingency plans, what they cover, when they were developed, how often they're reviewed. I know you've been there a little while, but let's talk about what you found and sort of how you've developed those plans and that evolutionary type of thing.
So we have contingency plans that have been in place. I think the last time they were reviewed was the last time they were updated was in 2011. So they're showing their age a little bit. The environment is built with some robust redundancy. We've kind of followed best practice in data storage and segregation of information systems. But we have had a couple of downtimes recently that accentuated some of our weaknesses, and those weaknesses existed around downtime procedures for each department. Most of our nursing staff was totally flummoxed when they had to regress back to paper because of a major system outage. And finding a means and a methodology of keeping those processes updated, validated, and tested is a challenge. We are embarking on a new effort this year, and we're less concerned about contingency plans and disaster recovery, and we're looking to redesign our technical and functional environment around business continuity, and our concept is that disaster recovery is what you do when your business continuity plans fail, and with that, we're going out and redesigning our infrastructure pretty much from the ground up to give us a more robust and redundant environment.
So, if I can ask, is the thrust to make the system so strong that you never have to get to paper, as opposed to training more and more about what to do if you do go to paper? So the focus is on just making sure you don't have to go there?
So I do not believe that we will ever be able to create an environment that will be available 100% of the time. After 30 years, I know that nature is smarter than I am and smarter than my staff in finding ways to confound us. But our intention is to really build an environment that presents minimal opportunities for the system not to be available. And that really covers a large variety of efforts around both network and data center and data storage and backup methodologies that we're in the process of redefining and putting together a plan to address, thinking that it's probably going to take us the better part of 36 months to implement most of this effort.
Very good. Ed, do you want to talk about your plans and answer some of those sub-questions?
Yeah, I mean, I'll do the best I can. So we also have done a lot that really does center around disaster recovery and downtime procedures, you know, and so knowing how do we still operate if the systems go down, and of course, depending on what level we're down, if it's just the EHR that's down or if it's our entire network or something, that changes some of the things. Some of the things we've done in the last few years that have really been helpful, though, as far as having a true downtime EMR. So it's not something that we can document against, but it's definitely something that's real-time live data up to the point of EHR going down, so you can still administer medication safely and, you know, get a 48-hour history, I think, of the patients from all the clinical stuff. So it's something, if you don't have the opportunity to print some paper in advance or something, depending on what the downtime was. But we do the disaster recovery planning annually. We refresh that, and I think it's partly because of where we are. We're literally right on the coast, on the water, in a hurricane zone. Knock on wood, we haven't had a direct hit in many, many years, but the potential is always there. I've been here 8 years now, so we haven't had a weather event in the 8 years that has caused any kind of downtime. But, you know, as long as we still make backhoes and plumbers, we're still going to have unexpected downtimes in all of our data centers. So what we've got, I mean, both from a plan perspective, I think it's pretty robust, but then it's how do you make that practical, and in the real world, what does it mean? You know, and so we do have dual data centers on site in different buildings, and we replicate that data real time to both buildings, so we can run from either one of those sets of data, which is cool. But we always all have restrictions based on what our EMR is, and some are better than others, I think, at utilizing that sort of active data center philosophy, and I think they're all getting better over time. But then from a true DR perspective, we do our backups on site, and we do replicate those sort of in near real time off site at another location that we lease some space pretty far away from here. So if it's a weather event, I feel comfortable we've got the data saved, and sort of like Dan referenced, you know, we could recover from that data, but it's not going to happen today, and it's not going to happen tomorrow, and it's not going to happen probably next week, you know. So in the event we lose 2 data centers here, we're down for quite a period of time. And in the event we have a hurricane, we've actually got to evacuate patients. I mean, that's our state says if a hurricane hits land at a Category 3 or above, because we're right on the coast, we actually have to evacuate patients. And so we have all these transfer agreements in place with a bunch of hospitals upstate and inland from us to take our patients. And today our methodology is we print off as much of the EMR as we can to send with each patient, so there's no expectation that users on the other end will log into something. I'd love to change that. I'm in talks about changing that. I think some of the questions further on down the slide deck will let me address, you know, what we're planning on doing around some of those other things later on.
So that's really an integration issue, right? I mean, I assume that these other hospitals are on different EMRs. or maybe not. But talk a little bit about that. That's interesting, what you're trying to work out with them.
You know, it is always an integration issue, so no matter how much work we all do and we think that the government's pushing us towards these systems still don't talk to each other. We've been working on HIE stuff around here for about 5 years with limited success. I mean, we got the technical capabilities, but it's the workflow challenges associated with really doing a good job. So yeah, if our systems are down, you know, there's really no data sharing we can do, and there's no repository in our kind of region, like I know some states have done a good job of that, for other people to log in and look at that information. We do more real-time HIE work. But what I'd love to do is, and that's what we're working towards, and at least in the design phases now, is have a true active-active, as close to, like as Dan mentioned, you never 100% guarantee, but as close to 100% uptime guarantee in a live environment as you can between multiple locations. And that's really, I think, what our plan will be going forward.
Very good. All right. So really the impetus for this webinar was the April 2016 report that came out from the government where they were studying the EHR contingency preparedness. I could send that link out if anybody needs it, about everyone's readiness with their EHR contingency plans. So, Ed, when you looked at that report, how did it make you feel about sort of your position and where you are?
You know, I think good and bad. It's always good to, I guess, benchmark yourself about what others are doing and sort of the national expectations and the things that you've got in place. I feel like we've addressed a lot of the elements, but no, there's so many weaknesses still, you know, and it's about like information security. You think you have your arms around everything, and that's exactly when you have a breach on something. So I think it's good to start talking about that and what the expectation level should be nationally on all of these items. And I don't feel like we're in too bad a shape, but we haven't really had to prove it in the real world. Testing we've done, but, you know, in the real world environment, knock on wood, we haven't actually had to implement these yet.
And you saw at the end of the report they're talking about, they recommended an audit program. So I guess that would get people's attention.
Yeah.
Dan, you want to talk about, oh, go ahead, Ed, please.
No, that's okay. Dan's probably smarter than me.
Oh, I question that statement. But for us, you know, when I looked at the report, I think my initial response was, you know, as an industry, we still don't get it. You know, we're thinking in terms of disaster recovery. We're thinking in terms of audits and reviews and contingency plans, but we're not thinking about the methodologies by which we can fortify our environment and minimize the opportunities for a system failure. So a little disappointed in that, and part of the stimulus in redesigning the workflow effort at Hunterdon. I think right now our contingency plans are reasonably okay. You know, we have a support model in place, we have plans in place, we have our data segregated, and we have a secondary data center and have all of those pieces. And we, as an organization, last year actually started an audit assessment, an external assessment of our environment and our plans, and are using those as kind of the spearhead on some of the changes that we're looking to make on fortifying our environment.
Very good. Dan, let me stick with you. I want to talk a little bit about spending and budgeting for these type of things. You can spend all the money in the world probably on your business continuity initiatives, but that's not practical. So what dictates it? You know, do you look at sort of where you want to get and try and get the necessary money to get there, or is there a certain percentage that you allocate out of your budget and you do your best with that?
So, Anthony, what I've done is I've incorporated the work that we're looking to do into my capital and strategic plan, so they're part and parcel of the work that we're doing, and we've defined it going out for the next 5 years. But if we really look upon, you know, why we do this, you know, why is it important? And it's really about, you know, patient safety, opportunity to improve quality, and opportunities to minimize our ability to make a mistake. So when we present to our board, we wrap it around an entire patient safety and staff satisfaction umbrella so that it has meaning and it comes home, and we're more likely to, you know, to get buy-in and move forward with the efforts.
Ed, you want to talk a little bit about spending and budgeting around these type of things?
Yeah, sure. And it sounds like we have similar organizations. You know, as we do our strategic planning and sort of refresh that every 12 or 18 months organizationally, obviously IT's in that discussion all the time. And so, in fact, the last time we sort of changed the format of what we do on it, we identified sort of 5 key overarching strategies. And then if you can imagine that across the x-axis, say, on a graph, and then going down, we had, I think we had about 12 elements that actually stretched across each one of those overarching strategies. And information security was one of those elements. Data center was one of those elements, which sounds crazy, but, you know, it was things like marketing and other things that would fall in there, and how they position, you know, how they touch each of those things. So as we're laying out all of our organizational strategy, we're thinking about things from an IT perspective, because we can feel like we can build in efficiency, we can improve the care delivery process, you know, the quality of care, patient safety, all the things Dan mentioned. And so at least there's importance, you know, at the board level, at the senior executive level, and in all the planning that we do in budgeting. But this stuff costs a lot of money. It used to be easier for me, you know, when I first started working here, the only departments that I had in my domain, I guess, were IT and medical records and some of the other kind of traditional CAO things. And so when it was time to sort of fight for capital spending, so to speak, I was just better at it than some of the other folks here. But my role has changed in the last couple of years, and so now I have departments like imaging services and some of these others that take a lot of capital too, our physician practices, just things to keep them going. And so now I totally get it. So, all right, we really got to balance how we spend the capital across the organization. There's still only so much to go around for everybody. And we're actually moving towards, and I think we'll hit that later with cloud stuff, we're trying to move towards operationalizing some of this a little bit more, not investing in all this, you know, heavy hardware and the 3-year refresh cycle that the vendors try to push down everybody. You know, I think that that's just starting to change in the industry, and I see that as a way for us to be a little bit better prepared just from a pure spending pattern and sort of flatten out that spend, operationalizing it, and not having to be all capital, you know, with its peaks and valleys.
And let's stick with you, Ed, and you may have touched on some of this already, but you've been in this business a long time, and I think we're going to talk about cloud a little bit later. And Dan mentioned more of the idea of keeping things in business continuity focus. But tell me any more you want to add on how your thinking has changed over the last 10, 15 years in your approach to, business continuity.
Yeah, I mean, I think it's fundamentally changed, and there's 2 things behind that. One is we all use systems so much more. They are embedded in everything we do. Our air conditioning systems, our telephones, our door controls, everything runs on our network now and is IP-enabled. And every way that we touch a patient is somehow got to do with technology, you know, whether it's telemedicine or it's EHR integration or whatever it is, you know, the clinicians can't operate without it. So it's critically important. It's not that we're just registering patients and getting a bill out, and that's sort of how it was in the good old days, you know. Now this is really touching every user, every clinician, every patient, everyone who kind of walks in our doors. So the importance of keeping the stuff running, it's like the old expectation of dial tone on the telephone systems. It just always had dial tone. And I think the other real fundamental change is technology just changes so drastically and so quickly. Probably virtualization was really the key driver behind that, I think. But the technology is so much better today and continues to get better with a lot of different options. Now, software vendors haven't all kept up, and it's complicated and hard to do to take advantage of some of that new technology. But the options that are becoming available to us from just a pure planning perspective for this have, I think, really increased.
Dan, your thoughts around how your thinking's evolved?
Well, you know, I would agree with Ed that the technology has presented greater opportunities and greater challenges. I think 30 years ago, for me, business continuity or disaster recovery was getting rid of tapes and going to spinning disk and being able to restore it in less than 12 hours. Now my thinking is that I have to create every opportunity to not have my systems go down. And for me, it really is concentrating on 4 different areas. It's looking at data itself, where it's stored, how it's backed up, and how it's recovered. It's looking at the data center, what I call greater communication, which is my local and wide area networks, and what I call lesser communication, which is, you know, voice, whether it's plain old telephone lines or voice over IP, as well as cellular service. So I look at those 4 pillars, and then we are attempting to build, you know, redundancy and robustness in all 4 of those areas to keep us going and keep us up and available.
Very good. All right, we're going to put out our first audience poll. So let's open the poll. Do you have a written EHR contingency plan that addresses the 4 HIPAA requirements? Number 1, having a data backup plan. Number 2, having a disaster recovery plan. Number 3, having an emergency mode operations plan. And number 4, having testing and revision procedures. We're not worried about being too scientific here, so if you're not with a health system, if you think of your main health system client, you believe they have these things in place. If you are with a health system, let us know. Do you have all those 4 elements in place? We're just trying to get a sample from the audience, so we will touch back on that. Go ahead and answer the poll, and we will touch on that. We'll review that in a few minutes. And now let's go to cloud. So Dan, let's start with you. What role does the cloud play in your contingency planning?
So I think you've probably heard me talk about this before, but my intention and desire is to be as cloudy as possible. So we're really looking to move my data center, you know, off the environment, out of the physical location, and put it in the cloud. Now, to do that, we thought there was some precursor work that was required. Certainly, virtualizing our servers was step number 1, and we've been successful in doing that. And the second phase, which we're currently rolling out now, is virtualizing our desktops. And we think once those 2 things are in place and we understand how they're working, we're going to start taking various applications and move them out to the cloud or to remote hosting sites, you know, whichever works with the particular operating system the applications are running on.
Very good, Ed.
Yeah, similar. You know, and I think we've had this talk for Anthony, so we're kind of early adopters of virtualizing desktops, and I love that. It's a great end-user experience. I think it gives you a lot of flexibility, can take advantage of some of these technologies, and it's built for cloud-based stuff. We haven't done a lot to date, though, I'll tell you. So everything that we've done, I guess you'd say, is all private cloud. You know, it's our lease lines to a data center that we lease from another company, put our own equipment in, so there's this complete demarcation. But I'll tell you, it's not because I'm afraid of it. I've heard a lot of people say, you know, the security concerns. I'm here to tell you, I think any of these large vendors that have big data centers are going to do a better job of data security, protecting that information, understanding multi-tenancy and all the things you have to do. So really it's been about the technology on our side and the capabilities to interact with that, the cloud-based stuff, and do it seamlessly and work. But I think things are there now, and that's our key strategy over the next 18 months is really data center simplification of our own data centers and moving these things to the cloud where it makes sense, and so that we may still have a primary data center, but I don't need to have a secondary data center. I don't need a third data center for DR. You know, I want the DR and the secondary data center to be a warm site that's not my equipment, that can run anytime and go fail back and forth, you know, in as near real time as is possible or economically feasible, or however you want to define that, I think.
Very good. All right, let's take a look at our poll results. Close our poll, and I'm going to share that with the audience. So we have 70% say they do have all those things in place, and 30% don't. So Dan, does that surprise you? That seems pretty high for all those requirements, or maybe you think that 70% is low.
No, I think those numbers are high. I believe that each of us do have something on paper that we would call a backup plan or disaster recovery plan. But do they really work? Are they functional? Have they been tested? I think that's where almost all of us fall short. You probably have it on paper, but is it valid? Is it reliable? Does it really work? I think that's a question that's still open and out there.
Right. Right. Very good. All right. Let's go to our next question. Let's start with you, Ed. And you mentioned being on the water and the issues that you have to plan for that. But maybe that's not the only thing you want to plan for. And different types of disasters, hurricanes, wildfires, depending on where you are in the country, earthquakes. And Dan, you can touch on the groundhog one. And then there's terrorism, cyber attack. You have totally different things, right? You have planning for a hurricane, you have planning for a cyber attack. Completely different scenarios. And then some you have evacuation issues. Obviously, with a cyber attack, you don't have an evacuation issue. You don't have the records transfer, Ed, that you were talking about. But I guess you need to use the realities of your geography and where you are to take some of these things into account. But go ahead and just talk about that question, if you would.
Yeah, no, it's a great question, and you left off my two favorites. So first of all, do you think you only have groundhogs in Jersey? We have groundhogs down here, so let's but the backhoes and plumbers, we do a lot of planning around these natural disaster type of events, and that's what we think about. What happens? Plus, it's hurricanes. That's our biggest concern, but we could have an earthquake. I mean, there's a lot of other things that could happen in this area. Certainly, and honestly, I would say 90% of failures are going to be more associated with a person or another piece of technology or a piece of equipment that's on site that causes the outage or the failure or something even worse. So those are the things. And the weakness, and I think Dan nailed it, we've got, I think, a good written plan, and I wasn't surprised by the 70% because I think just through compliance with high tech and everything and the risk assessments we've done, most people that bubbled up as something to mediate, is make sure that you have a really good disaster recovery plan. You at least need to speak to our financial auditors every year, do a big risk assessment of the IT capabilities, and that's one of the things certainly that they want to see, and that it's a viable plan. But it's the tabletop exercises. It's hard to do a real disaster plan and actually implement it. You can do bits and pieces. It's hard to do a complete failover. I don't care how good your systems are. It's very, very difficult, and I think will have an impact on the business. But at least the tabletop stuff, we sure don't do it hardly at all. And most people, I think that's where they struggle, is to talk through those scenarios because they're real and they're going to happen. And, cyber attack, it's probably as likely as anything for us, more likely than a hurricane for sure.
Very good. Dan, it's a good time for your groundhog story.
No, I agree with that. I don't worry about the natural disasters. I think I have a greater chance of realizing a system event because of people or equipment that virtually I control. But as Anthony has alluded to earlier this fall, we had a major outage of our clinical system that lasted about 13 hours as a result of a groundhog that had fallen into a utility hole and decided to munch through our fiber optic cables that connected the primary data center with our secondary data center and our ambulatory buildings and centers. So our outage encompassed not only all of the clinical systems, but all of the telephone services other than cellular as well. I don't think I ever in my life would have imagined that I had to prepare for a groundhog eating through my fiber. I do not at any point remember that wildlife management skills was a necessary job requirement for a CIO. But it's nature finds a way to mess things up. And I think the best thing we can do is to be flexible enough and design our models and our recovery methodology and our environment so that we can respond as quickly as possible. And it doesn't matter if it's terrorism or a system malfunction or a natural disaster or a groundhog. But creating a model in which I know that a failure is going to happen and how do I get the systems back in operational as quickly as possible, I think is the more critical roadmap. Kind of think of it as you know, the magic of the American Constitution is that it can change. So I think the magic of a contingency plan is that it has to be flexible enough to adapt to whatever might be thrown our way.
Right, and let's stick with you, Dan. One of the report findings, and this is just common sense, was that hospitals reported using planned and unplanned EHR disruptions to improve their contingency plans and prepare staff for future disruptions. Well, I hope so, right? So the incident you had, and almost you almost want some minor incidents, not some major catastrophes, but because, as Ed mentioned, you know, exercises are only going to get you so far. Near misses can give you an incredible amount of learning that you can incorporate into your plan. So the plan not only has flexibility to deal with many things that happen, but it should be flexible in the fact that you're continually using any type of learning to change it and tweak it, right?
And that's correct. So with our groundhog incident back in the spring, once we were, you know, fully restored and back to routine operations, we did a root cause analysis. We involved our quality department, our security department, certainly IT, our various user groups, our super users, and part of the some of our administrators. Went through the root cause analysis, identified opportunities where we can make improvements, and have started a process of putting all those things in place. And I will tell you that although there were some technical things that we think we can do differently and are doing differently, the real big eye-opener was the lack of opportunity for our clinical staff to use downtime procedures. We literally had nursing staff and physicians who were completely flummoxed by having to use paper. So we've gone back and are retooling our orientation and our training modules to make those part of those training events, making the paper methodology part of those events.
Does that have to become sort of an annual training exercise, like required, you know, you have to go to this class or you're not going to be able to practice, and then, you know, for those extreme conditions when they do have to go back to paper, they've got to know what to do, right?
So yes, and we are looking at this as being an annual event because we anticipate that we will be modifying our procedures on a regular basis.
Right.
So that was springtime. We've already made 2 modifications that have caused us to change what we do for training. So this will be a part of our annual education requirement for all our clinical and business users.
You know, that, Ed, and we can bring you in here, there's, you know, hospitals have said if you don't get trained on the EHR or certified, you know, internally, you're not going to practice medicine here anymore. We've had some hospitals that put that stake down in the ground and say that's how it's got to be. We might get there, we might have to get there from, you know, EHR backup procedures class. You have to have taken the class or you can't practice. I don't know if we're going to go that far now, but your thoughts on that or the idea of learning from the near misses or incidents that happen?
Yes, well, first I need to add one thing to Dan's discussion. I can't believe your root cause analysis didn't lead you down the path to just hire Bill Murray for a groundskeeper, but I don't know.
I can't tell you how many Bill Murray pictures showed up around this facility.
But, you know, we have done that to some degree, Anthony, is we've had things that we see are mandatory, and I think that healthcare has a history of telling folks that this is mandatory, that is mandatory, and not really holding people accountable for it. But we've done that. When we just did an upgrade on our EMR, we went live about 3 months ago, and just to a new iteration of the same vendor. But there were some, you know, fundamental differences for a lot of people, and we actually said the training is mandatory for all employed people. So that was employed physicians and all of our nursing staff primarily that had the biggest impact. And if they did not complete the training, they did not get a their updated password to get into the system. So, you know, we sort of forced that issue, and we've done that here with a few other things that were not IT related, you know, in the organization, and we've held people accountable and that don't work here any longer. So I think you have to do that. And then we've got annual competencies. So same thing, we've done sort of the computer-based training modules for some of our EMR stuff, and we do talk about downtime procedures, but I think Dan's right. It's hopefully so rare for most people that when they have to implement it, even with the annual competency training, you forget or you don't remember, you know, and you don't know quite what to do. And it is a patient safety issue. It really is something to be concerned with.
Ed, I want to just follow up with you on that answer. Obviously, you didn't touch on the concept of those who aren't employees, those dreaded, you know, I'm joking, those dreaded physicians that just admit to the hospital. I mean, if we leave them out of the formula of being required to understand downtime procedures, what are the effects of that in an outage? Yeah,
I mean, it is something to be concerned with, and certainly we had really good participation, so I don't mean to exclude them. It's just that we have less control from an employee perspective. But I guess when you boil it down from a privileging perspective, we have the ultimate control of what can go on. We do have pretty good cooperation here, and again, smaller community, I think, than what Dan's in, and it's a little bit easier. The relationships may be a little bit different. And honestly, I think fundamentally most people want to do the right thing anyhow, and will do that. So it's getting better all the time, but we don't have any policy around that.
Yeah, well, you know, folks are always a little nervous about upsetting the admitters, so that's not unusual. All right, we're going to go with our second poll, and let me open the poll right now. Have you had an unplanned EHR disruption that caused delays in patient care? Now, this is an anonymous poll, so don't be afraid that we're going to know who you are and publish this information. This is all anonymous. Have you had an unplanned EHR disruption that caused delays? I didn't say harm. We're just causing some delays in patient care. So you just answer that question, and we will come back and discuss it. All right, Dan, let's start with you on this one. How do you manage BAAs, business associates and business associate agreements, regarding contingency planning? How can you ensure they can support? How can you ensure they can support you if their systems go down? Is that something you ask them for, their plans, and look at?
We do as of 2016. Mm-hmm. Earlier this year, we started asking for not only to sign a BAA, but to share their recovery plans with us. A majority of our vendors have done that. A surprising number of vendors came back and said they didn't have one, and there were a few who said, no, we're not sharing that, which is going to cause us to have to go back and reevaluate our relationship with them.
I would imagine.
But for the most part, I think at least our primary clinical vendors have been pretty forthcoming with that information.
And, you know, what are you looking at? Are you just looking at a reasonable approach, that they've thought it out and are taking a reasonable approach? I mean, do you imagine coming across possibly plans that for a business associate that you say these are insufficient and giving them that kind of feedback? Just give me some idea how this could play out.
So Anthony, right now we're just looking to see if there's a plan in place, and I'm not looking to make a value judgment on it, whether it's a good or bad plan. But I think that's going to be evolutionary. You know, my number one goal is to at least document that my business associates have a disaster recovery plan. I imagine at some point moving forward, we'll get into a didactic about how useful or effective that plan is. But honestly, I'm just not positioned either staff or resource-wise to start doing those kind of assessments and analyses.
Ed, what are your thoughts on how you're going to handle these type of things?
Yeah, we're actually behind. You know, I think we talk about it, but we're not pushing it to the point that Dan just mentioned, and I think that's a good takeaway for me. But we do have this expectation, and I think that's where we get a little bit of bite from the BAAs now, that a business associate is legally responsible to carry out all the things they're agreeing to in the business associate agreement, you know, and sort of keep things up and running both ways and protect the information, which is really what that's all about. the way that they're expected to. So I feel like there's at least a little bit of legal bite in there, but I know for a fact we're not pulling them and taking that next step and actually looking at what their contingency plans are. And for me, that's a takeaway I'm going to have for today, and I appreciate it.
Very good. All right, let's go back to our poll. Let's close the poll, and we're going to share the poll results. So we see that 67% have had unplanned EHR disruption that caused delays. 33% have not. And I think the report indicated that this is quite prevalent. And of course, we don't really have a definition of how long the disruption was, how significant, but that it caused delays in patient care. Certainly the majority have experienced something. Dan, does that surprise you? I guess not, considering what you've been through.
No, I'm actually surprised that 33% have not had a disruption in patient care.
Yeah.
So no, I'm not all that surprised.
Ed?
I totally agree with Dan. I thought that number would be 100%.
Well, maybe they were nervous about having that information come out, so they didn't trust me on the confidentiality. Just joking. Okay, what type of staff should the CIO ideally have to cover EHR contingency planning? Dan, I want to start with you because you made the comment about staffing. So, and we need to put this in context of the size of the organization in some way, beds or revenue, but give us some example of your thoughts on size versus dedicated resources and personnel. Let's not talk budgeting because we already talked that, but let's talk about people.
So I don't think it has to,
go ahead.
So,
go ahead,
I don't
please.
think it has to do very much with size of your organization. Because I do believe that there needs to be a dedicated group to manage contingency planning, testing, updating, validating, policing, and all that. So I think the number of people might be a corollary to the size of your organization. I imagine that a little community hospital like mine would have fewer people than a large New York City academic medical center. But it is not one person for sure. It is a team of people, and it has not only IT or technologically savvy individuals, but it also has participants from the user community and user departments as part of that team.
So we're talking about specific people, Ed. That's what Dan's talking about, specific people where this is what they do. This is not just one of the things you kind of throw on their title and be like, yeah, you have a full-time job, but oh, by the way, you're in charge of business continuity. What are your thoughts around that, dedicated people?
Ideally, it'd be great if you could do it, and I think scale's got a lot to do with it. So we're an organization of about 1,750 employees. I think we've got about, 35 or 38 in IT altogether between applications and stuff. But on the technical side, on the engineering side, we have 5. And 5 is not enough for managing, over 3,000 users out of that group besides employees, 15 different locations, all those things that we do. So dedicating a person is really complicated. Our CISO basically helps with the risk management piece of it, identifying the gaps, working through the disaster recovery plan from a paper perspective with our technical team, and then we've involved outside vendors. I think for me, that's the only way I can do it. They have better expertise on the technologies than we'll have because we're sort of more generalists here, I think, than specialists, and they understand certainly as things are changing over time. But I'll tell you, it's as important as it is for who's the technicians behind this, how does the X's and O's work and all that stuff. From the planning perspective and what our plan looks like, we involve a lot of other people, like our patient safety officers involved. We got clinicians involved, people from some of the ancillary departments, because they're the people we're impacting, and that's our core business. We're not an IT company. We're a healthcare company. We're just trying to figure out how we can implement IT so that we can deliver healthcare appropriately.
Very good, very good. All right, we're winding down here, but I want to touch on this other issue and start with you, Dan, because you kind of touched on it before, about the regulations. So the first question is, this is sort of advice to colleagues. Is it enough to be in line with regulations and say, hey, I've covered all my bases, I've checked all my boxes that the government wants, so we're good? So that's question one, and question two is, do you feel like more or different regulations should be in place to make sure hospitals are ready for downtime?
So let me answer the second question first, and I'm a little bit of a libertarian and resent the idea of people telling me what I have to do. But understanding that that is reality, I generally think in terms of what is the right thing to do, and work backwards from there to make sure I'm ticking off all the boxes on the regulatory requirement side. I like to use meaningful use as an example. Meaningful use did a whole lot of things, none of which was make use of healthcare technology meaningful for the clinicians or the patients. But we've all ticked off those little boxes and gotten our meaningful use dollars. And I think in many ways we have to do the same thing with business continuity and preparedness. Yes, we have to respond and check off the boxes, but we have to build a plan that goes beyond that and is meaningful to, my organization and my patients and, more importantly, my clinical and business staff.
Ed, your thoughts on these issues?
Yeah, I think I'm in alignment. It would be nice if it was capable of the government coming up with the appropriate measures to put them in place, because to me, it's a national security issue. It's definitely a patient safety issue at the micro level, but when you look at the macro level, it's a big deal. There are some things we shouldn't be allowed to do, and one of those things is not have a good disaster recovery plan for our health information. I just don't know how you would sort of put your arms around making regulations behind that. I'm sure legislators would figure out a way to do it, and have it be meaningful and have it be something that would make sense for all of us.
Very good. I just want to remind the audience that you have a couple of minutes. If you have any questions, go ahead and send them in. Otherwise, I'd like to get any final thoughts, advice, or lessons learned. So let's start with you, Dan.
Lessons learned are really pretty simple. Be robust, be redundant, be pragmatic, and make sure that whatever you design is flexible and has the alacrity to help you respond as quickly as possible.
Ed?
That's good advice, and that's why I like to call myself all the time as a pragmatic optimist. So you definitely want to have the plans in place. You definitely want to test those plans, talk it through, do it from a technical perspective. You're going to need it someday, even if you think you aren't. I think that's the big thing. You don't want to be caught. What was it, Vice President Cheney, right? Quail hunting, I think. Where you just kind of turn your head, close your eyes, pull the trigger, and wet yourself when something happens. And I don't want to be that. We want to be more prepared for that.
Very good. All right. Well, that's about all we had time for today. I want to thank when you close out your window, you're going to see a post-event survey. Please take a minute to answer it. I want to thank our panel consisting of two of our very good friends, Dan Morreale and Ed Ricks. You'll receive an email when our archive recording has been posted to our YouTube channel. For those of you with the CHIME CHO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here. And if you've asked us to do so, we will. If you'd like to see a webinar, if you'd like to produce a webinar panel such as this on a topic of your choice, contact Nancy Wilcox for more information. If you need a certificate of attendance for another CEU program, you can reference the final slide in this deck. And of course, go to our website to view our upcoming schedule of events. And we have one coming up soon on the cloud, moving to the cloud. So those of you who are here today may be interested in that. So once again, I want to thank Dan, Ed, our attendees, and everybody have a wonderful day. Thank you.
Thank you, Anthony.
You got it.